Yeah, I think, yeah, there's always compelling idea, even with the polypill or statins, that we just should treat everybody or treat everybody above a certain age. I have some concerns about that. I just don't think that's the best approach. I think the group's heterogeneous enough, and there is some implications of using statins in the quality of life, even not just side effects, but how people feel when they take medication. So I myself is not 100% in favor of just across the board treating everybody. I think we can do better in defining people that may need it or may not need it. Of course, there will be some uncertainty, and we might be more aggressive even in the uncertain group, but I would favor more trying to stratify things a bit better rather than just going for the treat-all approach. That's personal choice. Yeah, I think that's an interesting question. I think we need to understand atherosclerosis in three different things of a disease process to think about how we should intervene on. I think one thing is developing disease, so having no disease to start in the disease process. A second step is the progression of disease and the plaque increasing and having more plaque in the plaque development. And the third moment is the plaque rupture and the plaque instability in the acute events. So it's three different moments where you can do interventions, and what you're talking now is the third moment, which is the vulnerable, or the moment where plaque ruptures or there's an increased risk of plaque rupture. And I think the idea of identifying the plaque that's vulnerable is maybe have some interest in a very acute setting when the patient's coming in and you want to know whether there is an acute event or not. But I think it's way more a systemic disease, and the approach should be way more directed to the personalized, individualized patient care, not plaque care. And in that sense, I think the vulnerable patient and approaching the vulnerable patient overall would be a more compelling strategy, at least for what we know right now about the medical therapy. There might be some changing paradigm if we have better data with specific lesion intervention, as people suggest for FFR, which I don't think we're there yet. But with potentially, if we could find therapies that target to the vulnerable lesions would really change the history of disease, then maybe, but I don't think we're doing that in the chronic scenario, only in the acute setting thus far.